Good afternoon, everyone. Very, very nice to see you. And it's a real pleasure to introduce Jess Radley, who's going to be talking to us about the needs and experiences of parents with psychosis and their families. Jess is in the third year of her DPhil here at the University of Oxford. She, interestingly, has a background in linguistics, which is why it's particularly interesting to hear her talk today about the results of her qualitative work with these families. I think it's so important. This is such a neglected group of families, their parents who probably have so many odds stacked against them. So I'm really grateful, Jess, that you've come to really share some of those experience and insights with us. So thank you. And that Jess will be taking questions at the end. Feel free to add your questions into the question and answer box as the talk proceeds, but we will be taking them all at the end. Thanks, Jess.
Great. Thanks so much, Mina. So, yeah, I'm Jess. I'm in my third year now, third year of DPhil in the Department of Psychiatry. And as Mina said, my project is looking at the needs and experiences of parents with psychosis and their families. And today I'm going to present some of my initial findings. So just to give you a bit of background on the topic. So what's psychosis? So just from the NHS website, psychosis is when you see or hear things that aren't there, which are called hallucinations, or believe things that aren't true, which are called delusions. And there are many other definitions, but we'll just stick with these for now. And how many people with psychosis are parents? So it's more than a third. And from these 3 studies, they found a range between 32 and 40% of people with psychosis who are parents, with twice as many women with psychosis being mothers than men with psychosis being fathers. And what impact will psychosis have? The impact on the parenting. The positive symptoms, which are hallucinations and delusions, may lead a parent to be overly involved in these symptoms and therefore not as attuned to the needs of their child. And the negative symptoms and side effects from antipsychotic usage may lead a parent to be quite blunted emotionally and therefore emotionally unavailable to their child. And hospitalization because of acute symptoms may mean they're also physically unavailable to their child. There are also indirect effects on both the parents and the child. Because having psychosis means you're more likely to be affected by stigma, by poverty, by isolation, by unemployment, by single parenthood, these factors will also have an effect on both the parent and the child. And so for the children, they're more likely than children without parents with mental illness to experience disrupted parenting. Because of these episodes of psychosis may mean the parent is emotionally and physically unavailable. These children are also more likely to have additional responsibilities, to take on these additional responsibilities, such as more household tasks, or they might even become young carers for their siblings or for the parents. And the children also have been shown to experience guilt and worry about their parents' mental health, to exhibit more emotional behavioural problems, and are at a heightened risk of developing a psychiatric condition later in their own lives. So for my DPhil, the chapters are as following. I'm going to update the proportional estimate of parents with psychosis, how many people with psychosis are parents, and any factors associated with this. And I'll be doing this using the CRIS network. So I'll be taking the NHS records of patients within Oxford Health. I've interviewed various stakeholders, and I'll be presenting that today. I'm going to use experience sampling methodology to look at the relationship between stress and psychotic symptoms and what affects this relationship. And I'll touch on that briefly at the end. And I've also done a systematic review looking at the evidence base of parenting interventions, of which it's a very weak evidence base. And because of that, I'll be doing a scoping review to look at what interventions have been conceptualized or designed, but haven't had a randomized control trial yet for this population. And throughout this talk, I'll be bringing up PPI, which stands for Patient and Public Involvement, to talk about how I consulted with parents with psychosis during my PhD about my research project and how their views informed my interpretation of the qualitative results and my design of the ESM study. Right, so the qualitative work. So I interviewed various stakeholders. I interviewed parents with psychosis. I conducted focus groups with healthcare professionals. I conducted retrospective interviews with an adult who was raised by a parent with psychosis. And I tied together the interviews of parents with psychosis with interviews with their partner, if they had one, or a family member if they didn't, and also a child aged 8 to 11. And the reason behind the age is because the parents were eligible if they had a child aged 3 to 11, and we thought children aged 8 upwards would be okay with being interviewed in this fashion. So today I'm going to present the interviews with the parents of psychosis and the focus groups with healthcare professionals. And so what did I use to do this? To analyze the results, I used reflexive thematic analysis. This is a very, very popular analysis. Brown and Clark first wrote a paper in 2006 about this, and they recently redefined it as reflexive thematic analysis to emphasize, as they state in their paper, the researcher's subjectivity as an analytic resource. So you use it to identify patterns of meaning across the database. What you do is you listen to audio recordings, you reread your transcripts, you familiarize yourself, then you code the transcripts, you look at things that just appear on paper, and you also look at things that might be underlying what participants are saying. You then group your codes together, look at initial themes where codes might start to form patterns. You then compare your initial themes to the data. Do they fit? Do they make sense? Then define and name these themes, and then you write something up. So the healthcare professionals I'm going to present the healthcare professionals first. So there were 3 groups. 2 were from early intervention in psychosis services, and 1 was an adult mental health team. They were eligible if they'd regularly worked with a patient with psychosis who was a parent. And this was defined as having contact with them at least once a month. And the aims of this particular qualitative work was to determine what are the needs of parents with psychosis from a service level perspective, and what barriers do healthcare professionals face in meeting these needs. Some of the questions I'd ask are around what they thought the barriers were, how they felt they could best help a parent with psychosis, what they thought what the main gaps were in parenting skills and knowledge, and whether they felt they could fully support their patients who are parents, and whether they felt they could support the children, and what stigma they believed parents with psychosis face. And so here are the results. So there were 2 themes. The first one was diversity of need in parents with psychosis, and it had 3 sub-themes. And the second one was role boundaries with 2 sub-themes. And I'll bring this slide up at the end, but what I'm going to do now is I'm going to focus on each of the 5 sub-themes in turn and explain them. So for the first sub-theme, the level of psychosis determines the level of need. And this was really addressing the fact that psychosis is an episodic illness. So health professionals felt that during the acute stage, it's the welfare of the child that's paramount, and the child may need to be removed during the acute stage. This professional identified that she felt one of her clients was a very good mother most of the time, but during the acute stage, she was risky and she tried to take her own life. But professionals would say themselves, it's an episodic illness. People can get better between times. There's no reason why they shouldn't be looking after their children between times. And yeah, when they're getting better, we can engage with them more as parents rather than safeguarding. So during the acute stage, it's looking at the welfare of the child, thinking about the child. And during stabilization, getting better, it's then what are the needs of the parents? How can I help them to be the best parent they could be? Right. So the next sub-theme, the effects of psychosis on parenting. And this is the diversity of effects, both diversity within the impact on the parent and the impact on the child. So some parents felt incredibly guilty. They felt guilty because of what they'd experienced. They felt guilty because they couldn't parent as well as they would like to. Some parents looked after their children perfectly well, but lacked self-care. This one mother in particular was described to never brush her own hair, but looked after her children. And on the other end of the spectrum, there were some parents who had neglected their children. They were so unwell, they were unable to look after the child needs. And as this healthcare professional says, it does vary between parents. Then the impact on the children. There were some children that experienced embarrassment. Their parents could be in the supermarket trying to cope. They could just be really embarrassed. Other children could get almost involved in parents' delusions. This parent here was described to be paranoid, teaching the child it's a dangerous world out there. You can't trust anyone. And then again, at the other end of the spectrum, there are some children who had seen trauma, who had seen police coming in, who had seen their parent being taken to hospital. Right, so the third sub-theme in this diversity of need was variation in parents' experiences. And this was really their ecological environments. So some health professionals identified that some parents had more need because they were single. So this one clinician said, it's the single parents, it's the mothers who don't have anybody around where social services step in and more often end up losing their children. Socioeconomic status also identified as leading to variation experiences. So this one clinician says, parents who write good letters, nothing happens to them, but if they're from a working class background, they're more likely to lose their children. And then another clinician identifies actually the label of having schizophrenia, like the stigma from having schizophrenia, can also lead to variation in experiences. So this one mother's trying to get increased time with her daughter at court, but the ex-husband and the court are wary of that because of the fact that she's got schizophrenia. Okay, the next theme was role boundaries, and the first sub-theme was perceptions of their role within the family. So how healthcare professionals would perceive their role with the parents and with the children. And there were actually two camps here. The first camp were working holistically. These healthcare professionals would demonstrate how they understood the importance of the parenting role to the parent. This healthcare professional says, we have to be very, very mindful to respect them as a parent, no matter what. Other clinicians would demonstrate how ways in which they would inquire after the child. I would ask them what they did at school today, what did you have for dinner? Because they're building rapport, but they're also just wanting to get some information about the child. How are they doing? Have they had their dinner? And some clinicians would go as far to even involve the children in the care of the parent, if appropriate, because they felt the child can give quite an honest overview of, I noticed mum doing this or dad doing this, so they could be involved if appropriate. Then there was a second camp of healthcare professionals, and I've labelled this one patient first, parent second, and that was taken directly from a quote. This person says, our first and foremost is to be about the individual who has been referred to us or who is at the centre as a patient before as a parent. And this group felt, why should their patients who are parents be given any special treatment because they're parents? And the reasons around this was around, training. We're not able or skilled or briefed as adult mental health professionals to be inclusive of the whole family. And they felt there were other professionals who could speak from the child's perspective, but the adult mental health professional should have the patient as their priority. And in a kind of meta way, one healthcare professional said at the end of the focus group, I feel almost negligent compared to what my colleagues are saying. These colleagues were in the Working Holistically group, about the conversation they've had with children about their parents and the psychosis. So role boundaries also came up with communication issues. So this was around when I asked about how they talk to parents about social services, about their children. Time and time again, healthcare professionals would say, I'm honest, I'm always honest about this. Things like, we're not trying to take your children away. That's the last thing we want. We're trying to put in extra support to enable you to continue to care for your children. And when I kind of pushed this, I was like, is this always possible? There was, some parents had said, I don't want any involvement. You're not entitled to that part of my life. And another healthcare professional would say, actually, sometimes I might not. So for example, if someone's particularly paranoid and it's affecting the welfare of their child, I might not necessarily involve them and say, by the way, I've been talking to 3 different agencies about you. Communication issues also came up when collaborating with other agencies, and particularly social services. So adult mental health professionals felt the social services were stigmatized against mental health, and particularly the word psychosis. And interestingly, in multidisciplinary meetings, when multiple agencies are involved in the care for a family, when adult mental health professionals wanted to withdraw because the parent's mental health is stable, but the child might still need support, they felt that other agencies looked to them more than they should because they didn't feel there was a role, but they felt that they couldn't withdraw because the other agencies were looking to them. So to bring that up again, what did I find? So diversity need among how much psychosis a parent might be experiencing, about actually what the impact of psychosis was having on the parents and the child, and diversity in need in terms of the parent's background, in terms of what was going on in the family's life. And the second thing was around role boundaries. And interestingly, there were these 2 camps of clinicians. Some felt that they could work holistically, some felt they couldn't, and struggled to collaborate with other agencies. So my aim was to define what the needs were for parents with psychosis from a service level perspective. And I found that it's not really possible to define specific needs due to diversity. So some parents coped well and had good support systems, but others had neglected their children and needed more involvement. And some children had witnessed acute symptoms or hospitalization, but others had never known about their parents' symptoms. But there were certain elements that were raised, like social support. The parents who had less social support did have more needs. And then what barriers do healthcare professionals face in meeting these needs? So there were these 2 camps, so working holistically, the health professionals that felt that they could work holistically and gave examples. But there was another group that felt that they couldn't. And the reasons were around time, around training. And I don't think we should just say to the second group, oh, why don't you just work holistically because these people can? Because there's a lot of burnout in adult mental health professionals. They also found like lack of effective collaboration with other agencies. So I really think this is all around lack of support for these healthcare professionals to be able to work holistically. Okay, so now I'm going to move on to my study with parents. So just to talk about the recruitment process briefly. So I presented the research study to the same teams I interviewed the healthcare professionals in. Then the care coordinators presented that to eligible service users. And if they wanted to take part, I got their details. After 21 people whose details I got, I interviewed 12. And they had to be diagnosed with any psychotic disorder, be a parent to a child aged 3 to 11 years old, and have contact with their child for more than 10 hours a week. And this was so we would hopefully recruit some more fathers who might not have full-time custody of their children. This were the demographics. So there were more mothers than fathers I interviewed. There was a reasonable spread of ages. I interviewed more people with the first episode of psychosis. And this was really just because it was slightly easier to recruit from the early intervention psychosis services. And then there are more sons and daughters, and I'm not really sure why. Okay, so the interview questions, I asked about a child's awareness of psychosis. I asked them, can you describe a typical weekday for me? And then I'd pick up on elements they'd raised. I asked how they felt their symptoms affected parenting, what they thought were the rewards or challenges of parenting, whether they felt there were many people in their life, professionals or friends they could turn to, whether they could talk about their child with their care coordinator. And if there was an intervention or a program for parents with psychosis, what would they want it to cover? Okay, so these are the results for the thematic analysis with the parents. The first one was the impact of psychosis on parenting, the impact on the ability to parent, the impact from them feeling the need to protect their child, and the stigma psychosis can bring. And the second theme was actually the impact of parenting on psychosis. So how the stress of parenting can lead to psychosis, and how during an acute episode of psychosis, how the content of symptoms could focus on parenting. And I'll just take you through these in the same manner. So the ability to parent. So psychosis will obviously affect the ability to parent in an acute episode. This parent says, I just wanted someone to take him away and look after him properly, not in a horrible way, but I just couldn't cope with him. I needed someone to look after him because I couldn't even look after myself. And that was the hard thing. Another mother, not as extreme, but would describe how she could look after their practical needs. She could feed them, she could bath them, but it was their emotional needs she wasn't able to give back to them. And this mother says, you can't be a proper parent because you're constantly worrying. Now, the impact on the children. So this mother describes how her son was a bit jumpy afterwards because during an acute episode, she was smashing some plates in the kitchen. So he was a bit jumpy about her being in the kitchen afterwards. This mother went into hospital, and when she came out, she felt she let him get away with murder. And afterwards, he was very, very clingy. And another mother describes how actually her child has become involved in her medication usage. And she asked her, have you taken your medication? And with the PPI commentary, they made a really important point, which was this theme, the sub-theme used to be entitled, I couldn't look after myself, let alone my child. But one of the mothers in the PPI group said, it actually didn't stop me parenting, it just changed my parenting. And you can see from the second quote that this parent could still practically parent. It was that she just couldn't provide as much as she would like to during the key episode. The second sub-theme was the need to protect their child. And this really all arose from me asking the question, what about their child's awareness of psychosis? How much does your child know? If they don't know anything, why don't they know anything? And this mother said, it was a very hard point in their lives, and I don't want to hurt them any more than they've already been hurt by it. The other reason was I'm trying to give them as normal a life as possible, and I'd rather keep it to myself and not worry them if I don't need to worry them. And one father said that, what I'm going to do is I'm going to sort this problem. And I'm going to say, well, look, 15, 20 years ago, I had this, but I've done this and I'm okay now. I've sorted it. Then when I asked about, what about if you're experiencing symptoms right now? This mother said, what I'd say is I'm a bit tired. Let's relax, let's chill out. But I wouldn't say I'm depressed, I'm exhausted, I can't move off the sofa, which is what I want to say. And interviewees who had multiple episodes of psychosis were better at hiding it or seeking help quickly. Like this father who said, I'd protect him from these things, which is why I'd have the same problem. If I had the same problem, I'd just go straight to hospital. And really importantly with the PPI, one mother said, I also don't tell them because I don't have the vocabulary to talk about mental health. Okay, so the next one was stigma. So parents with psychosis had faced stigma from friends, so from other mums don't really understand and they're a bit scared because of it. They say, oh, she's a complete psycho because she's got psychosis. They'd face stigma from professionals. This mum's telling a story about social services here. So I needed help, not criticism. And she describes how other mums have done awful things, but she always makes sure her son has proper dinners, proper everything. So why did she get social services, is what she was saying. There was also, and I didn't get this with the first reading, but going back to the text, there was this underlying a presence of self-stigma. And parents would really try and reassure me about how normal they were now. So some would say, that was a thing in the past, and I'm back to normal. It was a thing that happened to me. Or this mum who said, I'm a good parent. I'm starting to believe it more. Yeah, I am. I have been a really good parent. And it's the fact that these parents have been through such an experience that really dampens their confidence, and then needing to get that self-confidence back and reclaim their identity as a parent. And interestingly, when I asked, what intervention, what program would you want for parents with psychosis, many parents independently suggested a peer support program. And it's most likely around the stigma. And as this mum says, because no one really understands going through psychosis. But in a group setting with other parents who'd experienced psychosis, understood what it was, you could share your experiences, and maybe, it could also be sociable, and you could share what had worked there. And the PPI as well also helped me to reframe this, not as just stigma from others, but self-stigma. Because mum said, it's not just others, you judge yourself as well. Okay, so the second theme was the impact of parenting on psychosis. And this is a theme because many of the parents within my sample identified triggers for psychotic episodes were around parenting factors, like lack of sleep due to their child, or stress due to their child's behavior, or postpartum psychosis. And it was clear how stressful some of these parents found parenting. So this mum says, I get a call from the school and I answer as quickly as I can. And normally it's because he's been naughty, he's done something bad. But I'm constantly worried, oh my God, what if he had an accident? I have to get to him. This other mother puts it really clearly when she says, I'm a full-time mum. I've not got a good balance in my life. All of me is to do with my children. So anything that goes wrong, it's like, oh, it's personal, it's me. I've done a rubbish job. And this was exacerbated when parents had less support. So this one mother said, I'm standing outside her room crying at bedtime, thinking, I just wish there was somebody here who could go through this with me and me not have to do this on my own. And with the PPI, so all agreed, but some saw a more direct relationship than others between the stress of parenting and psychotic symptoms. And the final sub-theme was the content of symptoms focusing on parenting. This was during an acute episode of psychosis. So this one mum describes how she felt something was testing her. Would I notice the lights? I heard my little boy come through singing, and I was like, oh, I'm just being tested. It's all about just being a good parent, really. And this mother believed that she'd killed her baby because her breast milk had turned to water. And then another mother talks about how she felt paranoid. She didn't want to take him outside. She wanted to keep him safe. She didn't want him to get any bugs or anything. And other examples were like believing their child's phones were being monitored. And again, with the PPI, this resonated highly with some, but not at all with others. So again, the results. The main two themes were the impact psychosis can have on parenting, but also the impact parenting can have on psychosis. And it's easy to think about how psychosis will impact parenting, and that's how I began this presentation. But in fact, it might be the stress from parenting that some people are experiencing that contributes to psychosis, which then has impact on the stress someone can experience from parenting. And it was really that this pathway, the stress from parenting impacting on developing psychotic symptoms or experiencing them, was more strongly supported by the mothers who presented more parenting-related stress triggers than the fathers. And the mothers also either tended to be a solo parent or to be performing the majority of parenting tasks. Also, a lot of the mothers in the sample had developed psychosis at slightly later age than usual, say like late 30s. But men, in contrast, would emphasize their role as like the head of the family or the pride they felt in being a father. I've just brought up the stress vulnerability model here and just talk about it quickly. So we all have a certain vulnerability to the presence of symptoms, for example, psychotic symptoms. And some people are very vulnerable, and it only takes a little bit of stress to get over the threshold to experience symptoms. But some people are less vulnerable, but with a big enough stress trigger, they will also experience symptoms. And it might be for these mothers that parenting or chronic stress in parenting was a big enough trigger to experience psychotic symptoms. And then another important finding was stigma, and the stigma not just from friends and professionals, but also self-stigma. And parents would talk about words they use to talk about psychosis, like having a nervous breakdown or something. And a lot of these parents had lost confidence and they had feared for another episode, and they really needed a lot of reassurance, both from themselves and other people to reassure them. And again, just the fact that many parents independently suggested peer support is important, to have someone that actually understood what it was like to go through psychosis. And so what was the conclusions from both the healthcare professionals' thematic analysis and the parents' thematic analysis? So a very important point that was raised was psychosis is episodic. So during that acute stage, it might be almost impossible to care for oneself or one's child. But when the parent's stabilizing, and it's more important for them to rebuild self-confidence and to refine their identity and importance in parenting. Also protection arose all the time. And for the parents, it was around not wanting to disclose symptoms, wanting to deal with it all themselves, wanting to keep their child safe. The healthcare professionals went a little bit further and demonstrated how actually in some cases when parents were experiencing paranoia, that this protection could lead the child to not be taken outside as much as the child would like to or should go outside. Okay, so I'm just going to finish off by talking about how my qualitative research has led on to my ESM study. So I wanted to particularly investigate the subtheme, the stress of parenting. So what is the relationship between stress and parenting and psychotic symptoms? And I wanted to bring in these factors that I found. So having a parent, the child's behavior, parenting self-belief, the gender of the parent. I'm just going to quickly talk about ESM. So why am I using experience sampling methodology? So normally in psychology, we often ask people to complete booklets and measures, and it's in a clinic, you get one snapshot of life and you're asked to reflect on the previous 2 weeks. This is the PHQ-9. So the second question here is, over the last 2 weeks, how often have you felt down, depressed or hopeless? But this is an accurate way of measuring mood. ESM in contrast, you're given a device to take home, you're asked the same question multiple times, and you're asked to report on how you're feeling right now. And it's better because it measures day to day rather than the clinic. And mood changes frequently throughout a day. So if you get one snapshot, it might not give you the whole picture. And actually, I'll be even that good at remembering how we felt over the last 2 weeks. Our current mood may affect our memory of our previous mood. So the design for my study, the first hypothesis is that stress due to parenting will affect positive psychotic symptoms. And this effect will be mediated, so will be partially explained by negative affect. And the reason negative affect is in there is because lots of previous ESM research, just looking at general stress and psychotic symptoms, has shown that negative affect is an important mediator between the two, a partial mediator. Then I'll be looking at the opposite direction. So psychotic symptoms will affect stress due to parenting, and that will be mediated as well. And the last hypothesis is that these 5 variables, these 5 covariates, will affect some of these 6 pathways between 3 variables in the box there. So social support, the child's behavior, parenting self-efficacy, coping strategies, and the gender of the parent. So the 5 covariates will be measured by a one-time questionnaire, and the 3 items in the box, negative affect, stress due to parenting, and positive psychotic symptom, will be measured using ESM. So, and the ESM questions look like this. So the majority of them are done on a rating scale from 0, not at all, to 100, and they use a mobile phone touchscreen to drag between on the slider between the 2 numbers. The negative affect questions are these 5. I feel down, anxious, insecure, lonely, guilty. And I've taken that from previous work that's been done by a university in Belgium, KU Leuven. It's been tested time and time again with those questions. Psychosis questions are a bit more difficult because there's actually quite a wide range of them and they're not very standardized yet. So I took all the ones I could find in the literature, and I took them to the PPI group and I said, which of these do you think describes your experience best? And I also changed the directionality of some of them from I feel like I can't trust people to I feel like I can trust people, and I feel like I'm in danger to I feel safe, because the PPI group commented that it's nicer to not always be answering like negatively phrased questions. Stress will be measured in three ways. Activity stress, so what are you doing? And then these 9 questions. And parenting activity stress will be the first, if they select the first one. And then the actual number will be calculated by the average of these 3 questions. I'd rather do something else. This is difficult for me, and I can do this well. Then event stress will be what's the most important event since the last beep. again, the 9 questions, and parenting event stress will be from, if they answer tick the first box, and then the number will be calculated by reverse coding, how pleasant was this event. And then social stress, who are you with? If they pick the first 3, it will be, I'll ask them whether you prefer to be alone. The phone will ask them that. And if that will be the measure of social stress. And if it's my child or my children, that will be taken as a measure of parenting related social stress. Yes, and they'll be asked these questions 6 times a day for 10 days. Great, so what are the next stages of this project? So I've revised and resubmitted a registered report to the British Journal of Clinical Psychology. And just to quickly cover what a registered report is, it's when you write an introduction and the methods, like a protocol, and you submit it to a journal, and you get peer review at that design stage. And if they accept it, then they will accept whatever you find in your results and whatever you write. You could write discussion well, I guess, but no matter if, as long as you've stuck to your method, they'll accept your results. And it's trying to get away from preferring, positive results. And I got some good feedback from that process. So I was asked to change the age range from 0 to 18 to 2 to 16. I was asked to use a different measure of parenting self-efficacy, and I was given a good review paper that I hadn't read before. So I changed it from the top C to the map. And I also added in a hypothesis. And this was because they said, why am I looking at stress due to parenting? I haven't even really justified why I want to focus on that. And it is because I do genuinely hypothesize from the qualitative research that stress due to parenting will have a large impact on positive psychotic symptoms and general stress. So I need to recruit 32 participants. That was done using a pair analysis, using previous data with an ESM study. And they have to be a parent to a child aged 2 to 16. They have to live full-time with this child, and they can have any psychotic disorder, excluding postpartum psychosis, drug-induced psychosis, or panic psychosis. And then that's it. So thank you very much to my funding body, Mental Health Research UK, and my supervisors, Louise, John, and Jane Barlow.